yet. All right, guys. Good evening. Tonight we're going to be going over Module 5, which is respiratory emergencies. All right. We've already touched on some of the anatomy and physiology of the respiratory system, but tonight we're going to touch on a little bit more, and we'll go from there. All right. So let's go ahead and get started. We're going to start off tonight with dyspnea. All right. That's the feeling of being short breath. All right. A lot of elderly patients in different scenarios will get dyspnea. Also, you'll get a lot of dyspnea on people who do a lot of exercising, running, or different things like this. Overweight patients a lot of times will also get this feeling. The most common complaints, of course, we get it out in the field when we get called out to a scene. All right, that's a lot of times our respiratory calls. That's one of the feelings that they first advise us when we get on scene. All right, that they're having a hard time breathing. All right. Let's go back over the anatomy and physiology. Okay, we'll go over the upper and lower airway obstructions, structures of the body. Obviously, the upper airway structure, you have the nasal pharynx, the nasal air passage, the mouth, the oral pharynx, the epiglottis, and then the apex of the lungs. Okay, that's the top part. And then you go into the lower. You have the larynx, the trachea, the alveoli, the bronchi, and then the main bronchioles. Lower, you have the bases of the lungs, and then, of course, the diaphragm. All right. Obviously, the anatomy and physiology is very important to any respiratory problems as long as you can listen and you know what you're looking for. Okay. Obviously, if you have a chest injury or different things like that, it's going to affect what happens inside the chest. Understanding a little bit about the upper and lower airway extremities sometimes will help you identify what's going on within the patient. Okay? Characteristics of adequate breathing. Okay? Normal rate and breath. Okay? We all know that a normal breathing rate for an adult is what? Someone tell me? 12 to 20 breaths per minute is about the normal. Okay? Regular patterns of inhalation and exhalation. Normal breath in and out. You guys remember a few nights ago we sat there and we talked about what is the average milliliters of breath that an average male takes in. 500 mLs is what the average is. Okay, so that goes in part along with the regular patterns of inhalation and exhalation. Good audible breath sounds on both sides of the chest. Remember, I told you guys that the best way to get used to listening to lung sounds and understanding what you're hearing is actually practicing doing it. Okay? When you listen to the breath sounds, you listen at the apex and the bases of front and back. Okay? You'll be able to pick up a lot of different things from different patients as long as you continue to start doing that. Okay? Obviously, regular chest rise and fall of both sides of the chest. Okay? Obviously, if you have something that's going on with flail chest or something like that, you're going to have unequal chest rise and fall, correct? So keep that in mind. And then obviously pink, warm, and dry skin. That's also a big indication of that everything is adequate with breathing. Okay. Now, is that true for every patient? No, but it's a good starting point. Okay. How the oxygen and carbon dioxide exchange. All of this happens where? Can anyone tell me? Right, it happens in the alveoli, okay? Basically what happens is the oxygen comes in as you take a breath. It goes all the way down your trachea, into your bronchioles, all the way down into your alveoli. Your pulmonary arteries bring in all the CO2 that your body is transforming, okay? And the CO2 and the O2 exchange happens inside of that. Obviously what happens is that the bloodstream and everything, the oxygen, takes in the CO2, pulls off that, and one goes into the pulmonary capillaries and the other one goes back into the pulmonary arteries, and you breathe it off. That's how that's where the oxygen exchange happens. But it happens deep inside the chest walls and inside the bronchioles and the alveoli. The pathophysiology is the common cause of respiratory emergencies is an increase of level of carbon dioxide in our arterial bloods. Who is one of the main patients that a lot of times this happens with? COPD patients. Remember I told you guys a few nights ago that a lot of COPD patients are what? They're called what? Hypoxic smokers, or they are basically hypoxic drive is basically what it is, okay? So over time, the respiratory center in the brain may work less efficient, okay? So where you and I, where we stand here, okay, we're breathing and we're taking in everything through the oxygen, and our brain knows what our normal levels of CO or O2 that we breathe in is normal. Where a smoker or someone else, it's always been in something in that situation to where CO2 is, their body gets used to that levels, okay? So their brain kind of thought, wait a minute, you know what, I'm not used to all this, so I'm going to start running off of this more, okay? So that's where their body is that they don't require as much oxygen, and they run off of CO2 more than anything, okay? And then obviously the hypoxic drive takes over to stimulate the respiratory system. And that's where you get that to where, if you remember that they say that a lot of COPD patients, you can actually knock out their hypoxic drive. You could, but do we ever withhold oxygen from anyone? No, we never do. So keep that in the back of your mind as well. Signs of inadequate breathing. Obviously, we've already said that a normal respiratory rate for an adult is 12 to 20. So less than 12 breaths per minute or greater than 20. Okay, unequal chest expansion. Okay, a lot of times that may be from a failed chest. Okay, or something like that. That could cause that. A decreased breath sounds on one or both sides of the chest. What are some of the things that could cause that? Punctured lung, pneumothorax, hemothorax, different things like that could cause that. Fluid in the lungs, you know, back up that. That could get decreased breath sounds. Most of the time that happens in the base of the lungs. Okay, so you can get it, you can learn, and you can listen to a lot of that if you start listening to the base of the lungs. You may be able to sit there and start listening to the apex of the lungs and go, okay, well, everything sounds good. You get down here to the bases of the lungs, you're like, wait a minute, what's going on down here? I really don't hear anything, or it's a lot less than what I hear up here. You come to find out that they have fluid in the lungs. Go down and look at their ankles. You start looking at their ankles are swollen, or different things like that. Okay, so those are some signs of inadequate breathing. Muscle retraction. Okay, a lot of times you get that up underneath the collarbones and different things like that. You'll see that pulling in. A lot of times you see that on children and elderly patients. Okay, would you see that? Would you really see any muscle retraction in Lee? Probably not. You know, but you may see it in Oz if he was really having a problem or something like that. So, you know, keep that in the back of your mind. Okay, pale and cyanotic skin. Where's one of the first places you're going to see it? Around the lips. Okay, that or even in their skin color. Okay, you'll see that right off the bat. You know, you'll be able to see they're pale, cool, clammy. That'll be another sign, because obviously they're not taking in enough oxygen to keep their body warm, pink, and dry. Okay. Cool, damp, clammy skin, we already talked about. Shallow and irregular respirations. Okay, a lot of times if people are having had fluid in their lungs or whatever else, they take real shallow breaths. Okay, they're not getting a lot in there because it either hurts or they just can't do it. Okay, and then pursed lips or nasal flaring. Okay, what's one individual who may have that pursed lips? Smokers, correct? A lot of times they get it because that's how. That's the easiest way they can get in the most air. Okay, and then of course nasal flaring. A lot of times you see nasal flaring on kids. Okay, but you do see it in adults as well. Causes of dyspnea: upper and lower airway and infections. Obviously cold, diphtheria. That's a respiratory disease that obviously affects the lungs. Okay, epiglottitis, obviously that affects your epiglottis. Croup, where's the most time you're going to see croup at? Kids. Okay, one way that you can help with kids get rid of croup is how, Don? Steam. Put them in a warm steam shower. Okay, that helps them out tremendously. Okay, so that right there, that's a good way to do that. And then of course pneumonia. Okay. Acute pulmonary edema, okay, that's one way, and then of course COPD and then asthma, All right, these are all causes of what most of the time smokers, elderly patients, different things like this, they're going to have either one or two or sometimes all of these. Okay, and that's what's going to cause a lot of their respiratory problems when we get called to these scenes. Okay, and more spontaneous pneumothorax. Who is an individual that may get a spontaneous pneumothorax? Okay, tell me. How about athletes? You ever heard of an athlete having a spontaneous pneumothorax? Basketball players do it. What's that? Spontaneous pneumothorax. Basically, they get air in between their lung and everything, and it actually happens. Basketball players will get it. Runners can have it. Those are just some of the common things that they can get. Anaphylactic reactions. Obviously, you know, anybody who's allergic to anything. Fire ants, shellfish, any of that stuff, peanut butter, you know, they can have any of that stuff. A mechanical obstruction of the airway. Anybody think of something other that may, don't do it. Can anyone tell me something other that may cause a mechanical obstruction of the airway?
Lifesaver.
Okay. Lifesaver. A what?
Raisin.
Raisin. Have you actually had that before?
Yeah, I've seen.
Okay, yeah, kids. Yep. Hyperventilation syndrome. Okay, that can also happen. All right. Some of these I've seen. Some of them I have. I haven't run on anyone's had hyperventilation syndrome, but it's possible. Spontaneous pneumothorax. I have run on someone that had. It was a runner. So. Patient assessment. Again, we've already went through this scenario, okay? But on respiratory emergencies, we have to make sure that we take these step by step and go through them very well, okay? So obviously, anytime we get a call, we're going to do a scene size up. Again, scene size up starts when the call comes in. All right. When we get called, if it gets called to a cardiac, all right. A lot of times when we get in there, what's one of the other causes that someone may be complaining about? Respiratory problems. So we need to fix the respiratory problem. If we fix the respiratory problems, sometimes that may help their cardiac. Okay. Obviously, you're going to have your BSI on. Okay. Your gloves, glasses. If you need a mask, if anyone has TB or anything like that. Okay. And safety, obviously, you know that you're going to take that into consideration. And then your NOI and your MOI. Okay. The nature of the illness and then the mechanism of it. All right. Were they outside when all this happened? Okay. Was it a car accident? Were they inside a bar where a lot of smoking was? Who knows? Okay. But you got to take all that in consideration. And then consider spinal precautions. Obviously, if there's a fall, accident, different things like that. A lot of times, elderly patients, they may just fall inside the house, but you still got to take that in consideration. Excuse me. And then the number of patients, and if you need additional resources. Most of the time, unless it's a vehicle accident or a multi-casualty incident, when your engine and the rescue should be able to take care of it. Okay? And if multiple patients with dyspnea, consider possible hazardous materials release. Okay? Now, in our district in this area, what are some of the areas that you may run into with? How about Pinch a Penny, where they have chlorine? Maybe Gladius. Yeah, maybe Gladius. Okay, yeah, I meant to tell you on the last one, multiple patients.
Yeah, I need it.
Okay, any of your marinas?
Yeah.
So, yeah, Fish House. Fish House may have, I'm not exactly sure what all they have in there, but I'm sure they... And hydrant, okay. So, a lot of that. So keep that in the back of your mind. You get a call to someone where somebody's having dyspnea or different things like that, you know, and you start getting 2, 3, or 4 people, think about that. You may want to step back and go, okay, you know what, I need to call in some more help and get some things in here and see what's going on. Okay, so take that into consideration. All right, your initial assessment. Obviously, your initial assessment is going to start with your general impression as you walk up to the patient. Okay, you're going to look. You're going to see whether or not how they're breathing. Are they tripods? Basically, what a tripod is they're sitting over and they're kind of leaning over because it's easier for them to breathe. Okay, most times someone when they're having problems breathing, are they going to be laying down? No, they're going to be sitting up. They're going to be, leaning over because that's easier for them to breathe. The more you lay down, the more pressure that they have on their chest. Okay? Their airway and breathing, you want to check their airway. Is it open? All right? Is it clear? What's their rate? What's their quality? Okay? Circulation, you're going to grab a carotid pulse. Or, in our situation, you're going to quick grab a hold of that pulse ox and you're going to throw it on there and see what their pulse ox is. Remember what I said before, though. Do not just take that in consideration and go, oh, look, you know what, their pulse is 90. Okay? Remember, we still got to look, we got to still grab a hold of the wrist and see whether or not it's weak, bounding, if it's thready, and different things like that. And then in your transport decision, okay, if we get there before EMS and EMS is coming out of zone, okay, you might want to sit there and go, call them up and advise them. Listen, I got a serious respiratory emergency here. This patient could crash at any moment. Who knows? Okay. A lot of times EMS is only a few minutes out from us anyway. So when you guys get there, obviously, to bag the patient, put an OPA in or something other like that, help them out, do it. Let me ask you guys a question. Can we bag someone to help them with ventilations if they're awake, sitting up, and talk to us? Absolutely. Okay. Focus, history, and physical exam. Okay. Try to get as much of this from the patient as you can, but if not, try to get some of it from the family members or a bystander. Okay. A lot of times, they'll be able to tell you, what kind of history you have, especially in the elderly patient. If it's at a nursing home and different things like that, you'll be able to have the chart and see, okay, they have a history of COPD or chronic obstructive pulmonary disease, whatever. So, and then of course, pay special attention to OPQRST. All right. Why do you think we would pay special attention to that? Exactly. Yeah. It'll help you focus down on what you exactly need. And then obviously find out what has already been done with the patient. If it's an asthma patient, have they already taken their inhaler? Did it help? Did it not? Okay. If someone's having an allergic reaction, they're having respiratory problems. Hey, are they allergic to anything? Yeah. Okay. Do they have an EpiPen? Well, no. They left it back at the house or different things like that. Okay. Let's help them out. Let's get that done. Okay. Then you're going to go on to your focused physical exam. You're going to listen to breath sounds. Again, this is a crucial part, guys. Okay. A lot of EMTs and different things like that, they leave that for the medics. Okay. Listen to the lung sounds. Listen to see what you have in there. See if you hear anything, okay? A lot of times we can't fix it, but at least that way you can sit there and listen and go, okay, look, you know what? I'm hearing crackles in the base, or I'm hearing a lot of fluid up in the upper part of their chest. That won't be a good thing if you hear a lot of fluid up top, okay? Most of the time you're going to hear the majority of it in the base of the lungs, and you're going to hear that towards when you listen in the back, okay? And then pulmonary edema, okay, where some of the areas that we can look for that are ankles, okay? So you're going to take a look at that. And then your baseline vitals, you're going to obviously get a pulse, which our pulse oxes are going to give that to you. But remember, still grab a hold of that wrist and go from there, okay? Your blood pressure. Blood pressure should tell you quite a bit as well, okay? Level of consciousness, capillary refills, okay? Obviously, you're going to check the respiratory rate. Again, less than 12, greater than 20. Okay. Sometimes somebody's going to be breathing within that 12 to 20 or whatever else, but it's a shallow. Okay. Skin color and temperature. Pain measurement. Okay. Ask them if they're breathing. If they're sitting here breathing, going, listen, does it hurt to breathe? And when you take a deep breath, is it hurting? Absolutely. Okay. Well, let's see. Have you had any injuries up here? Did you fall? Who knows what could have happened? Okay, and then of course your pulse oximetry. All right, most of the time that's any first thing that we're going to put on anymore. All right, your interventions. One of the main things that we can do is oxygen. Okay, obviously when you throw that pulse ox in there, again, what I like to tell everybody is throw that pulse ox on before you decide on what oxygen therapy you're going to put. Okay, if they have a pulse ox of 98. Okay, but they're still having a respiratory problem, okay, and they're having trouble breathing. Well, their pulse ox is 98, I'm going to just put them on a nasal cannula. Would you do that? No. Put them on a non-rebreather, you know, because obviously they're having a problem. Yeah, granted, they're still getting a good, you know, they're still getting oxygen within, and it's still showing up that, look, you know, they got a good amount of oxygen inside their system, but they're having trouble breathing. Put a non-rebreather on them. Put it only down at 12 or 13 liters per minute. Remember, our new O2 bottles go up by halves, okay, or ones. Put them on there. You don't have to go to 15 or 20 anymore like the older bottles did. Possible airway management, okay? You may have to put in an oropharyngeal airway, okay, an OPA. You may have to do it, all right? But they're going to not have to have a gag reflex, okay? Remember what I said. Hopefully by the end of the year we'll have MPAs, all right? You can still throw those into a patient even if they have a gag reflex. It'll keep that airway open, all right? And then position the patient, okay? If that patient's laying back, they're complaining about having trouble breathing, sit them up. You know, hey, listen, let me try to sit you up a little bit, see if that helps. Let's sit you on. A lot of times this happens in bed. You know, well, let's sit up, let's sit you on the side of the bed and see if that helps you breathing a little bit, okay? And assist the patient in a prescribed inhaler, especially if they have asthma, okay? And we're going to go over the steps for that in just a second, okay? You got to sit there and take all of this stuff into consideration when you're doing this patient assessment. And then obviously documentation, okay? If we be EMS there prior to, you know, unless they get there at the same time, okay, it's imperative because a lot of the medics like to know what was their pulse ox when you guys first got here, okay? Well, when we got here, it was 93. Okay, what have you done? Well, we put them on a non-rebreather, and they're up to 95 or 96. Okay, well, obviously this isn't going on. Let me see where else I can go. Okay, or you may sit there and go, okay, you know, they were at 93. Their, you know, their respiratory rate was 22, whatever it was. We put them on a non-rebreather. We set them up. We gave them the oxygen at 15 liters per minute. Calmed them down a little bit. Their pulse ox is at 98. They're feeling a lot better. Hey, look, you know what? Okay. We can go from here, okay? So they're going to want to know that details. And then you're going to go through your detailed physical exam. Once all your life-threatening situations are treated first, okay? Remember, we want to take care of the airway, breathing, and circulation first, okay? That's what they're pointing out. That's what you have to fix. Once you do all that, then you go into your detailed physical exam, okay? Go through a little bit more closely, look at everything, take time at the chest, listen, and go on. And then, of course, you're going to go into your ongoing assessment. Now, with us, do we really go into ongoing assessment a lot? No, because ongoing assessment is going to be into transport. Now, sometimes we may get involved in that if it's like at the tip of the island or in Northwest Bradenton, 99th and 17th or something like that, Robinson's Preserve. We may get into that if they need a rider. Okay, you're going to, obviously on your ongoing assessment, you're going to repeat your initial assessment, reassess your vital sign. On a unstable patient, how often do we reassess vitals? Every 5 minutes. On a stable patient, every 15 minutes. Normally, what are you going to do? Maybe get 1, 2 blood pressures because the hospitals are so close. Okay. Reassess your respiratory system, okay? Obviously get back in there. See whether or not the things that you have done has helped them, okay? See whether or not giving them oxygen has helped. See whether or not if you've assisted them with their inhaler, if that has helped their clear up their lungs. Well, listen, I listened to the lungs prior to helping them with their inhaler. Let me listen now. Hey, listen, I don't hear as many crackles, or I don't hear, you know, whatever it was you heard prior to that, okay? Remember, don't be afraid to listen to the lungs. Okay, if you sit there and you listen to the lungs, and the mechs get there and listen, I listen to the lungs, but I'm not exactly sure why I hear it. It just doesn't sound right. Okay, you know, hey, listen, at least you're listening to something. It may clue them in something. All right, let me listen, and go from there. Okay, and be prepared, obviously, to assist with ventilations. You know, if this patient is breathing way too fast, one of the best ways you can help them is grab that BVM and go, listen, I'm going to help you slow your breathing down, okay, and make them, you know, slow their breathing down. A lot of times that'll help them as well. Or, obviously, if they have less than 12. You know, one of the rules of thumbs in paramedic school is less than 8, you're going to intubate. Obviously, we can't intubate, But if you get down to that area to where they're only breathing so many times, you're going to have to help them out. Okay? Communication and documentation. Supplemental oxygen, again, be a non-rebreather mask. All right? Remember what I told you guys, our non-rebreather masks, you know, they work best from 10 liters on up. Okay? Most of the time, on a stable respiratory patients having some mild dyspnea or something other like that, put them on 10, start them out with. Okay? A little bit more problems, bump them up to 15. Okay? Obviously, somebody that's having, you know, a little bit of problems with breathing, you're not going to put them on a nasal cannula. Okay? A prescribed inhaler. Obviously, can we, per our Manatee County protocols, assist? Yes. You don't have to call for medical direction or anything else like this. But there are the steps that we have to go through. Okay? Our protocols state that we can help the patient with them. But we have to make sure that the medication is the patient's. We have to find out when the last dose they gave themselves, because a lot of times these patients will try to give one themselves. Okay? So find out about that, and then you can assist them with that. Okay? But obviously you have to make sure that it is the right patients, because how many times have you went into a mobile home park or different things like that, and, well, I have chest pain or whatever else, and I'm going to give my husband one of my nitros. No, you're not, you know, because it's a different dosage, all right? It may not work for them. All right, so you're going to make sure that it's the right patient. You're going to make sure it's the right medication for that, and then the right route, obviously. Okay, most time, what is it? It's sucking in and breathing in, and it's done. Okay, you're going to check the expiration date, and you're going to check the dose. All right, and then administer repeat doses if it's indicated per your protocols. All right, so make sure you read up on those protocols and make sure you know exactly how many times that we can assist them with that. All right. We're almost done, guys. Obviously, prescribed inhalers will give us some side effects. Okay? It's going to increase your pulse rate. It's going to make these patients nervous, and it's going to give their muscles tremors. All right? Especially if you sit there and they've already sucked on this thing 2 or 3 times prior to you getting there. Okay? These people are going to be wired for sound. All right? They're going to be sitting there shaking, and you're going to be going, okay, wait a minute. Maybe this isn't, you know, something more going into this. All right? But keep that in the back of your mind, all right? And with these prescribed inhalers, all right, some of the most common side effects is the heart rate's going to be up, muscle tremors, and they're going to be nervous, all right? So keep that in the back of your mind, all right? Any questions whatsoever with respiratory emergencies? Remember, never withhold oxygen if these patients need them, okay? If they need it, give it to them, all right? Just like I said, just because it's a COPD patient does not mean, you know, back in the day, oh, don't give them oxygen, you can knock out their hypoxic drive. Give them oxygen. Just be, you know, just sit back with it and go, okay, look, you know what? I need to make sure that I don't give them too much to help them. Because remember, inside their brain and inside they're working off of their CO2 drive anymore. We're not like you and I. Okay? Any questions whatsoever? You guys ready for a test? All right, let's go.